Hello, I'm hematologist-oncologist Dr. Tony Talebi. I'm with Dr. Stephen Bekanich, Associate Professor of Medicine at University of Miami and Director of Palliative Care. Thank you for being here.
Thanks for having me.
Can we now please discuss what hospice care is?
Okay. Hospice is a very structured way of giving care near the end of life. And so this is a Medicare benefit, so people enter into this benefit. Hospice basically becomes their insurance. It's all paid for, and it's meant for patients that are near the end of life, where life-prolonging therapy is either no longer desired, no longer appropriate, or no longer effective. It is oftentimes, unfortunately, given during the last few days of life, but ideally it should be given during the last several months of life. So we have a tendency in the United States to refer to hospice very late, but we know that if we refer to hospice earlier on, that we have measures that show that quality of care is improved, and that lifespan is certainly not shortened and actually may be improved. And this is sort of the take-home message for hospice patients or patients considering on going on hospice, that their lifespan is not going to be shortened at all compared to if they did not enter into hospice. Hospice care is very much about quality of life. And so we know that near the end of life, that patients with significant illnesses can be burdened by many different symptoms. So pain, shortness of breath, nausea and vomiting, seizures, depression, anxiety, etc. Hospice care focuses on those things, and typically, when you get good hospice care, those symptoms are an emergency. Those symptoms are oftentimes not thought of as emergent in traditional medical care, but your quality of life, your experience through the hospice system is aimed at making sure that you don't suffer and that your family members have the practical support that's needed to get you through this phase of life.
I see. So which patient is appropriate for hospice care?
Okay. When people have an illness that there's no longer a cure for, then those patients clearly are appropriate for hospice. But also, when patients have said, you know what, the burden of my illness, the burden of the treatment that I've been getting for my illness outweighs the benefits of the treatments that I've been getting for the illness, that is oftentimes a sign that the discussion should be had with the primary provider, the oncologist, and the patient and their family about hospice. Because it doesn't have to be at the end of a disease. A patient can say, you know what, I have had enough of this type of care. I want to focus just on my symptoms and my quality of life and move into hospice care. The hospice benefit has been made for patients for a 6-month period. Just because 6 months goes up does not mean that the hospice benefit ends. We actually have had patients on hospice for years. Sometimes patients will be on hospice and be discharged from hospice because things have become better for them. And so it may be that hospice is appropriate now. Maybe 3 or 4 months down the line, it's not appropriate. It can be a very dynamic process.
You know, there are times when we know hospice is appropriate for our patient, but either the family members or the patient refuse. What do you say to those situations?
Okay. You know, we try to get to the bottom of why they're feeling that way. You know, oftentimes when we have these discussions, we don't ask why enough. We don't get to the root of the problem. You know, if we look at, here in Miami, we have a large Latin American population. And if you trace back the root word hospicio in the Spanish language, it often means things in other countries in South and Central America that have a negative connotation. A home for delinquent children, a home for people that have psychosis. That doesn't sound good to someone that was born and raised with that word hospicio and bringing that to our medical culture in the United States. And so a lot of this winds up being exclamations. There's a feeling out there that when you get into hospice care, you've sort of given up a fight. Well, I would say that that's not true. So when you enter into hospice care, it doesn't mean you're giving up. It doesn't mean you're not fighting. Hospice doctors want you to live as well and as long as you're able to. And they do things that will help you achieve that. But I think that there have been lots of cases in the media and the news about patients getting into hospice and then dying shortly afterwards. A real good example of that is Elizabeth Gore from last year. She entered into hospice care and died within a 48-hour period. That was a highly publicized case. And what that really means to us is that, again, hospice patients are not referred to hospice early enough, and it should be several months past that you start thinking about hospice and having those discussions. And oftentimes it takes patients and families more than one discussion, more than one clinic visit or session to get used to this idea and to accept the realities of what a patient might be going through. And so just bringing it up once and then them saying, no, we're not ready for this, we're still obligated as providers to try to get them to understand their situation. They can always say, you know what, hospice just isn't for me, and that's okay, but we're obligated to try to do what's best for patients. And all the data that we have shows that when patients wind up choosing hospice, that their quality of life, their quality of care goes up, and that caregiver stress that the family experiences, that burden goes down.
I see. Can the patient's oncologist continue to follow him or her while they're in hospice care?
Yes. A key issue in transitioning care, and it doesn't have to be just to hospice, is this feeling of abandonment. So, you're taking care of someone for months or years, you have a good relationship with your oncologist, you trust them, you like them as a person, and then the idea of going into a different realm of care and leaving that provider behind is understandably very scary. And so the primary care physician or the oncologist can remain the primary physician when a patient is in hospice, and that's very important for patients and families to understand. It's oftentimes not even understood by the oncologist, and it's something that we encourage. The hospice doctor can have a role as a consultant if there are problems with family dynamics or other symptoms that maybe the primary provider may not be used to taking care of. The hospice doctor is still always there in the background, eager to help. But the oncologist or the primary care provider can still be the patient's primary physician.
What are the different levels of hospice that one can obtain?
Okay. So when you enter into hospice, there are different levels of care based on what you and your family are going through. Hospice care is really directed towards home care. And that comes out of the idea that when you ask patients and families where they would actually want to die, it's overwhelmingly it's within the home. It's not in the hospital with a bunch of lines or tubes in you. And so hospice care is directed at home, and there are these different levels of care. So the basic hospice care is where aides and nurses and social workers come into the home on a regular basis, oftentimes every day, and are there for a couple of hours. So they help with bathing, they help with the care of bladder catheters or other lines or tubes like IVs or feeding tubes. They help make sure that the sheets are changed and so forth. They help with the medications, making sure that patients and families know how to take medications, that they have enough medications. The care is really meant to come to you. You don't have to go to the doctor's office anymore. You don't have to go to the pharmacist anymore. You know, the care is delivered to the home. There are going to be times when patients have more difficult to control symptoms. So nausea and vomiting or pain, they might have a crisis. And under those circumstances, they can get what's called continuous care or crisis care. And that's when the hospice will inject a team into the home, often a nurse or a nurse's aide, on a 24/7 basis. So they don't leave. It's meant for a short period of time, 1, 2, maybe 3 days, until the crisis is abated. The final level of care is inpatient hospice, and that means that the patient actually leaves the home environment, which again we try to do everything we can to avoid, and go into like a hospice hospital or hospice inpatient unit. It's very much like a hospital. It's oftentimes within large hospitals. And they get much more intensive care because they're having some sort of crisis that just can't be dealt with at home. The minority of patients need to go into this inpatient hospice setting. But it's important for families to understand, you know, if things are not happening at home the way we want to, we always have a place to go. We never want patients and families to feel backed into a corner or like they only have one option.
I see. Yeah, I think you mentioned this before, but can someone actually come out of hospice once they've been in?
Yes. So, you know, again, we try to protect autonomy or the right for patients and families to make decisions that they feel like are most in line with their goals. And you don't have to stay in hospice. We've had plenty of patients who enter into hospice and say, you know what, this is really not the care that I want. You know, most people don't want to be in an ICU at the end of their lives. Some people do. And if they try hospice and it's not for them, that's okay. You can leave and go back into sort of the traditional medical track. That's both allowed, and if hospice is not meeting your goals, I would say encouraged as well.
I see. Would you please explain what DNR or DNI is, and do you recommend that for someone that enters hospice?
Yes. So we're talking about advanced directives or code status. Specifically, if your heart were to stop or your breathing were to stop, would you want to get CPR? Would you want to have defibrillation, electricity delivered to the heart? And would you want to be put on life support? Certainly saying that you don't want those things, meaning I choose a DNR, DNI status, is not a criteria for entering into hospice. So the alternative to being DNR, DNI is what we call full code. You want all those things. If you enter into hospice, you can choose to be full code, or you can choose to be DNR, DNI. And I think that we're going to talk about this a little bit more in the next video. But the important thing for providers and patients to understand is that you don't have to choose DNR, DNI to go into hospice care.
I see. Well, thank you so much.
It's been a pleasure.
Thank you for watching. We hope this has been educational for you.